Fact or Fiction, our show where we bring you the latest and greatest in all things infertility and answer your questions live. I am your host, Dr. Rahi Victory. I am a reproductive endocrinology and infertility specialist. And next to me is my hidden sidekick, trustee Tarek Ibrahim from Ibrahim Strategies Group, who runs our show for us. You'll hear him, but we've never shown him before, except for that one time you like crawled behind the camera.
And when that video went on YouTube, it was edited out that way.
Oh, did you edit out the YouTube video? Oh, so some of you got a chance to see him briefly. So we've got a good show for you tonight. I've decided that the infertility world has come a little bit to a grinding standstill because of the fact that COVID has kind of knocked out a lot of research opportunities. So the really important studies have not really been coming at the pace we would like. And rather than focus week after week on just COVID, which thankfully seems to be dying off slowly now, we are going to branch out and do some gynae stuff. We're going to do some obstetrical stuff. And where possible, if it's related to infertility, we'll relate it. But we may even just do some basic things like non-pregnancy associated bleeding, or how to manage preterm labor, or what risk factors there are, and so on. So if you like those ideas, give us some thumbs up. Definitely comment. Make sure you hit that subscribe button and let us know how you feel about the new path we're taking. So one thing that we get all of the time are questions about first trimester bleeding. So what does this constitute? Any instance in which patients experience bleeding in the first trimester, so in the first 12 to 13 weeks, where they have spotting, pink, brown, they get clots sometimes. It can be associated with no pain. It can be associated with pain. And the question is this predictive? What do I do? How do I manage it? And so on. So I'm going to take you through the gynecologist or obstetrician or even reproductive endocrinology approach to how you explore this, what to expect, how to manage it. Then we'll review some evidence on how to diagnose it, what sort of things can you look for, and what kind of things can you expect if it happens to you, because there are different outcomes that people have looked at. Excuse me. So let's start with the basics. Who does this happen to? Well, 16 to 25% of women who have become pregnant will experience some degree of bleeding in the first trimester. So it is extremely, extremely common. That's roughly somewhere between 1 in 6 to 1 in 4 women that will end up having some degree of bleeding in their first trimester. So the commonality of this is extreme. We see it all the time. It's something we experience on a daily basis. Right now, all of our patients are going to the Windsor Regional Hospital triage unit. We are getting, at least several women per day that are coming in with bleeding. So we see this all the time in common practice. Many centers have set up what's called an early pregnancy assessment unit, where you can walk in, see a physician, get an ultrasound, get your lab work, have all of that done and get your answer as quickly as possible. It often will take an extra 2 days because we have to see the trend in your beta HCG, especially if it's really low. But the reality is that if you do that, you have that kind of scenario, that setup where you have an EPAU, it's really helpful for patients because there's no 18-hour, 12-hour, 8-hour, whatever it is, wait in an emergency department. You can just get in, get seen, have your treatment set up, or at least your future diagnosis set up, and that way your management is much, much more efficient. So we're going to be setting up an EPAU here probably in the new year. I'm very excited about that. We will have Windsor's first EPAU, and that way patients who are worried from anywhere in the region can just directly come here, no referral needed, kind of on a walk-in basis, and we can handle them. So in terms of the differential diagnosis, meaning what kind of possibilities are there when someone comes in with bleeding? So that's really important. So number one, the first kind of step in the flowchart is the patient pregnant or are they not pregnant? So you got to do what's called a beta HCG in order to determine if they're pregnant or not. Obviously, if they're not pregnant, then we don't need to worry about the whole pregnancy side of things. You got to determine why they're having irregular bleeding, and that's a gynecologic problem we won't discuss tonight. If they are pregnant, so they have a positive beta HCG, which is internationally defined as more than 5 milliunits per million unit international units per liter, then we have to decide what we're doing with those patients. Okay. So step one is, what are the possibilities? And the possibilities are, you're having what's called a threatened miscarriage, which means that you have not miscarried, but you could miscarry. You could have a incomplete miscarriage, which means you've already started passing some tissue, but not all of it has come out. You could have a complete miscarriage, which means everything has come out, but you didn't quite realize it, or you did realize it, there was cramping and bleeding. Or you can have a missed abortion, which is when the fetus has passed away, but you didn't know it because the only symptom obviously can sometimes be bleeding. And then in those very rare circumstances, you can either have what's called a septic abortion, which is almost universally caused by someone attempting to perform their own abortion. Those are those, God forbid, closet coat hanger abortions. Or by someone who has an ectopic pregnancy, where if they have an ectopic pregnancy, you can get vaginal bleeding and some pain. So what are the big differences between most of these? Well, the first designation is there pain or no pain? So if there's pain, you have to be prepared to rule out an ectopic pregnancy versus all the other diagnoses. And then also in the pain category will often be either a complete or an incomplete, because they would usually be associated with cramping. Once you're past the pain part, you have to figure out if the cervix is open or closed. If your cervix is open, you either have a complete, an incomplete, or what's called an inevitable, which means nothing has come out yet, but it possibly could. Or will, in fact, not just possibly could, but will come out. If you have a closed cervix, you're either missed, meaning the fetus has passed away, but it hasn't come out yet, or you're threatened, which means the fetus is alive, but you're having bleeding and we don't know why. So how do we differentiate between all of those things? Well, we basically have 3 essential tools. So tool number 1 is your beta HCG. So there's lots of controversy out there, but there's a basic rule of thumb to follow, which is that your beta HCG in the early part of the pregnancy, meaning up to about 6-7 weeks, should be doubling every 48 hours. So if you had a beta of 100, 48 hours later, it should be 200. 48 hours after that, it should be 400, 800, 1600, and so on. So it's an exponential rise because it's a factor of 2 each time. So that's the basics. What's acceptable? You need a minimum of a 60% rise. So I don't want everyone to run out and panic if their beta went from 100 to 160 in 48 hours, because that's actually normal. So it's okay to have some bleeding and still have a normally rising beta, and that's all right. I just had a patient the other day who had done IVF at my previous fertility center, which when I was no longer there, she had failed multiple embryo transfers. We just did a new IVF cycle for her. She sent me a message showing that everything was perfect, and her beta was initially good just from the home pregnancy test. She then noticed the next pregnancy test, there was not a positive, and she'd had some spotting, so she was worried it was going down, but it had risen an appropriate amount even within a short period of time. So that's one really easy way we keep track of this. We follow your beta HCG. You do need the 48 hours to understand exactly what's happening. But if you have a minimum of a 60% rise, there's a very high likelihood that everything is probably very, very okay. Number 2 is ultrasound. So if you're having pain, you must have an ultrasound because you have to rule out an ectopic pregnancy. That is absolute. How much of a beta HCG do you need for us to be able to see a pregnancy in the uterus? Well, it depends on who's doing the ultrasound and how good the actual ultrasound is. The very, very best ultrasound technology, like we use in our clinic, a Voluson E8 from GE, you're going to see a pregnancy at a beta HCG level of around 1200 with a transvaginal ultrasound. So you'll see a sac inside the uterus. If you are doing it transabdominally, you need about 5,000 or 6,000 for the beta HCG to be able to see a sac. Most centers are using somewhere between 1,500 to 3,000. And if you are over 3,510 milli-international units per milliliter, you're actually looking at a 99% positive predictive value that you should be able to see a sac inside the uterus. So that's really important for everyone. You may not see a fetus, but you should see the sac that the baby is growing in inside the uterus. So that's really critical. We use that beta HCG threshold to help us determine when to do an ultrasound. So if you have no pain whatsoever, you've just had some spotting, you go in, they measure your beta, it's 300. We can do an ultrasound, and there's no harm in doing so. But if you don't see anything, it doesn't mean there's anything wrong, because you're way below the threshold for us to see anything in the uterus. You do want to rule out the ectopic, but in the absence of seeing something up where the tubes or the ovaries are, we call those the adnexa. You might see that term thrown around a lot online or in the literature. Then you're really looking for what's happening in the uterus. And inside that uterus, we really need that minimum threshold of 1,200 for the best of the best. 1,500 to 3,000 on average. Above 3,510, you got a 99% chance you should see a sac. The last thing that is really underused is actually progesterone. So as long as you are not on progesterone, meaning you're not taking any progesterone, then your progesterone level will actually reliably exclude a pregnancy versus non-viable pregnancy. So if you have 6 nanograms per milliliter on a progesterone test, which is 19.1 nanomoles per liter, then you have a 99% predictive value for it being viable or non-viable. So if you're below 6 nanograms per milliliter, there's a 99% chance you will not have a viable pregnancy. So that's also really important. So if you have a center that can quickly adjust to this and test your progesterone, it's entirely reasonable to do so, and can add further support to your beta HCG to tell you if things are going well or not. And to be honest, through training, through clinical practice, seeing all of my colleagues, virtually no one is checking progesterone levels. So this is something we may start implementing into our practice more and more to help people get an earlier answer so they have some information to go on. Of course, in the fertility world, if you've gone through fertility treatment, the vast majority of you will already be on progesterone, which makes this completely useless because that artificially inflates your level. And so it doesn't mean anything when you're taking progesterone and then measuring the progesterone level. So what kind of outcomes can we expect? Well, the biggest question is, what are your chances of miscarrying? And the answer is, it's extremely controversial. So in prepping for tonight's talk, I looked up a bunch of different studies. There's one right here that says association between first trimester subchorionic hematomas and pregnancy loss. And they actually say that in this group of women, which was 2,446 women, they found no association between a subchorionic hematoma and loss. And this is a 2019 article. In another one that I read, they said that there is an increased risk of loss and that it's quite a substantial increase in the risk of loss. It can be basically double the normal rate. So normal background rate of miscarriage is about 17%. So about 1 in 6 pregnancies will result in a miscarriage. In this particular instance, if you're doubling that, you're really getting up into the 30s, so 1 in 3. So yes, it does probably increase your risk. When they looked at this specifically within the realm of the patients that have had assisted reproductive technology, some interesting stuff came out from one study. So number one, the majority of cases with bleeding came from instances where they transferred more than one embryo, and they had what we call vanishing twin, where 2 pregnancies started, but one of them doesn't continue. And when that regresses, it can sometimes cause bleeding and certainly panic. So the bleeding incidence in a single embryo pregnancy was around 4%, and in a vanishing twin was 8.7%, so much, much higher chance. The second part that was quite interesting that they found was that there's a much higher chance of bleeding based on how many embryos you put in. So people are always saying, I want more than one, I want more than one. Put in 2 because I want a better chance. But it actually increases your risks of bleeding the more embryos that you put in. And it is correlated with the actual number. So you put in 1, you get a certain value. You put in 2, it's a higher percentage chance. You put in 3, it's a much higher percentage chance. So, and then greater than 3 was even higher. So obviously there's a lot going on with the number of embryos you put in relation to the outcome for bleeding. And this is critical because we always get pressured by our patients to try and put in more and more embryos because they want a higher success rate. The reality is you're not just increasing the risk of twins. It looks like you're actually increasing the risk of bleeding. And because of increasing the risk of bleeding, you may be increasing the risk of miscarriage. So that's also really critical. What are the outcomes you can expect if you don't miscarry? Does it have an impact? Are you okay if you manage to continue the pregnancy? What happens? Does it cause any impact? Well, it actually does. So preterm labor, actually, you know what? I'll start with bleeding. So your risk of bleeding is 350% higher in your second trimester if you had bleeding in your first. Your risk of bleeding is 185% higher if you had bleeding in the first trimester, in the third trimester that you would bleed. So 185% higher chance you'll have bleeding in your third trimester. Preterm labor, 127% increased. NICU admission, 75% increased. Preterm birth, 64% increased. And extreme preterm birth, which is very, very early, 24 weeks or less, you're looking at a 205% increase in your risk of extreme preterm birth. So yes, there are increased risks of complications from patients that have bleeding. Do we see this? Honestly, these are risk numbers, so it doesn't mean that 65 or 75 or 205% of you are going to have these outcomes. It just means that you go from a baseline of 10%, let's say, to 30%, but that still means 70% of the patients are going to sail through this. So keep in mind that when we're quoting you risks, they're risks. It doesn't mean that number, reflects that everybody's going to have this outcome. It just means that's how much higher the chance that this event would happen to you actually is. So the next question, of course, everybody asks is, what can I do? I don't want to bleed. I don't want to lose my pregnancy. I've worked so hard for this. What do we do? So the reality is there are some things we know cause miscarriages or increased risks of bleeding. Trauma, heavy lifting and straining, excessive exercise may be associated with it. Absolutely smoking, drinking, drug use, no question whatsoever, huge increase in risk. Smoking, for example, is a 400% increase in your risk of miscarriage. Any kind of hard drug use, marijuana is the same thing as well. All of these things can contribute to your risk, and it can contribute to your risk of miscarriage even if your partner is doing those things. So it doesn't have to be the woman that's in risk from doing these. Even if the male is doing it, it increases your risks as a female. What about medications? Are there any treatments? Well, the big one obviously is progesterone. So what does progesterone do? Well, we believe that progesterone helps support the pregnancy. And because we use it so often, we are big believers in progesterone. Looking this up, I don't think there's actually a more controversial subject out there other than endometrial scratching, which still has people saying yes and no. But use of progesterone in the newest studies seems to suggest that when you look at it overall from all of the different studies that are there, you either do a meta-analysis or a network meta-analysis, that there's either very little benefit to starting progesterone after they've started bleeding, or that it may be beneficial, but only in women that have previously had pregnancy losses. So the newest of the new in the Cochrane database does show that that may be beneficial in those patients, but in a select group of patients. For everybody else, if you weren't already on progesterone before, so you're a garden variety patient out there, you didn't go through fertility treatment, you start bleeding, and you say, oh my God, what can I do? When we give you progesterone, which we do, because probably has no negative side effects, it's very unlikely to help in that specific scenario. No data has shown yet that it's supportive. And there is even a New England Journal study in 2019 which said that it actually did not make a difference, but they started it quite late. So I'm not sure if that's as useful or not. How does it work when you start it earlier? Well, unfortunately, none of the studies have ever looked at that. Fertility specialists all strongly believe that it prevents it, but we don't have data to support that because no one's willing to try that study because we don't want anyone going without the progesterone. So I'm not sure we'll ever get the answer to that. It's too hard to answer because if I tell all of you, and I'll ask this question, you can tell us yes or no online, maybe put up a poll or something if you can. The reality is, if I said to you, hey, you can either go on progesterone, which has no significant downside and may prevent you from having a miscarriage, or you can skip it because we want to do a research study and compare you to women that do take it, how many of you would be willing to not take it to find out what happens? I'd be super curious to know. So let us know. Make sure you're hitting that like and comment button and let us know what you would do. So what's the most important message to take away from all of this? Most important message to take away from all of this is, number one, not everyone with bleeding ends up with a bad outcome. The vast majority of women that have bleeding will go on to have a completely normal pregnancy, have no complications or problems, and end up with a beautiful, happy, healthy, bouncing baby, boy or girl. Number two, you must be careful about that horrible ectopic pregnancy because many of you are at risk. Really, everyone's at risk. And some people are even higher risk based on their risk factors. And so if you're having bleeding or pain, you must get seen so that we know what's going on with you. Don't hesitate to be seen because ectopic pregnancy is still one of the number one reasons for maternal mortality, even in the developed countries. And then the last thing is that there are ways to very easily discriminate between what's a normal pregnancy and what's not a normal pregnancy. And we can do that and help you out by testing your betas serially. We can check your progesterone levels, and you will need an ultrasound eventually. So thank you for joining us for that part of Fertility Fact or Fiction. Make sure you hit that like button, comment for us. Let us know how you feel about this new value to doing these non-fertility topics. And make sure you subscribe. Hit that subscribe button on YouTube or join us on Facebook, which is now Meta, right? It's now Meta. So join us on Meta and follow us on Instagram and Twitter. Let us know how you feel. So we'll definitely be back next week with another cool show, although we're trying to figure out the time because I am going to the Men Having Babies conference in Brussels to give a talk. So I'm super excited about that. So we're not sure if we'll be doing Tuesday or Wednesday, but I'll figure it out and I'll let you all know as soon as possible. In the meantime, we're going to switch over to live question and answer session. So I'm assuming we got some questions. It's crazy. Okay, fire away. I'm going to need a drink. All right.
Sure.
Non-alcoholic drink. I don't drink. This is Canada Dry. I've never had a drop of alcohol in my life.
I had my first consult with you on Friday. Just want to say thanks for your amazing work and care for patients.
Oh, that's awesome. Thank you. Well, that's a nice way to start off.
Yeah,
You saw my post today, right? What a great way to start the morning. Yeah, those folks were in Scotland and they reached out for help and I kind of guided them through what to do. And now they're 12 weeks pregnant after a lot of failures. So that was like the ultimate high to wake up on, you know? It's kind of a good way to start the day. A great Monday, you know. Yeah.
I even
yeah.
felt excited.
You felt excited. That's awesome.
My second FET was October 21st and got a negative HPT this afternoon.
Oh, sorry.
Beta tomorrow. Am I out? If it fails, what would you recommend before FET3? I only have 2 embryos left, a day 5, 3 BB, and a day 6, 4 BB.
Well, first of all, I'm very sorry. You're not out because, like I said, some patients have negative home preg tests and they still have a positive and normally rising beta. So you're definitely not out. Wait for your beta. As far as the thing to do, if God forbid it doesn't work, it really depends on what's been done for you before. So it's really hard to answer that kind of question. I certainly, after 2 failures, hit the brakes and investigate everything to make sure I know everything about you that's going on. So I never want to miss any details. So we check for infection. We check your chromosomes. We check his sperm DNA if we didn't already, which is pretty unusual because these days we check everyone for their sperm DNA. We check for your thrombophilia screen. We'll look at your habits. We'll look at your diet. We'll look at your body mass index. There are all sorts of things that go into this that we check and double check. We might check for endometriosis. So there are many, many, many different factors, and you need a really thorough evaluation. And I think I'm really proud of our team. That's one thing we do exceptionally well. We help people figure out what's wrong. I had a patient call me. She had a previous successful pregnancy at another center. She's been trying again and again and again. They're doing the same thing over and over again. She said, I don't understand it. I literally figured it out in 2 minutes. Her husband's on a drug that is cytotoxic because of his personal health history. And, that's obviously having a huge impact. We reviewed the data together. So sometimes it's really easy for me to pick up on stuff that, is important. I don't necessarily want to say that other people have missed, but yes, that's the case sometimes too. But you need that kind of thorough evaluation. Simply doing embryo transfer after embryo transfer is a really good way to make the fertility doctor rich and to make you poor, frustrated, angry, and depressed. So don't do that. Make sure you get answers before you do further embryo transfers. And reach out to us, do a consult with us. We'll help you through it without having to become our patients even. We do that all the time. I mean, this couple in Scotland, I literally haven't met them yet, but we helped them and they're pregnant now. So that's something we're really, really good at. And I love doing it. For me, it's not about making you my patient. It's about me helping people. So if we can help you succeed, we will.
Well, I apologize to the Instagram people.
Again, dude, what's going on with that?
My phone and it just shut off on them. So
Oh, no. Instagram folks, you got to re-ask your questions because Tarek blanked you out. It won't show up on mine, eh?
No. And there's billions. So.
Oh, billions. Well,
yeah,
the billions of grammars, you need to re-ask your questions, please. Yeah.
Okay.
Wait, actually, you know what? Somebody asked us one ahead of time. Can I pull that one up?
Sure.
It's here. From Allison. Question for tonight's live.
Okay.
First one, right hand lower front ligament pain while 30 weeks pregnant. Can't get comfortable. Tips. Get an ultrasound to make sure there's nothing wrong. If there's nothing wrong, make sure there's no kidney stones, bleeding, any problems like that, a fibroid. Assuming that it's none of those things, you're perfectly fine. Yoga, meditation, Tylenol, see a chiropractor. There isn't a lot you can do if it's round ligament pain. Second, wondered, given the large number of patients, what the probability is of actually having Dr. Victory in the delivery room. So I was on call Saturday. I did 10 deliveries. So I was 100% for all of them. He is one of our absolute favorite people and has truly supported my husband and I through a difficult fertility journey these last few years. So I hope he can be there on our special day. So thought I'd ask the overall chances. It's currently 1 in 12 because there's 12 doctors. So you have a 8.25% chance of, is it 8.25 or 8.75? I think it's 8.25% chance of getting me as a doctor. So I'm sorry. But, oh, it's 8.125, right? 1 in 12 is 8.125. No? 833. Oh, it was close. So yeah, 8.3% chance of having me as your doctor, Allison. Sorry about that. I love doing it, but it is exhausting. Very exhausting. Yeah.
Okay. How viable is a natural IVF considering only one egg retrieved and there are multiple stages where it can fail?
It depends on which study you read, and it very much depends on you. We actually have really good experience with it. So we find a lot of our patients are getting about a 40% chance of success. It's not amazing, like 90%, 80%, that kind of thing. But keep in mind, patients that are doing natural IVF are almost universally doing it because they either aren't responding to the meds because their ovaries are weak, or they're having a religious issue with doing it. So if it's a religious issue, you're going to do better because your egg quality is not compromised. But if it's because your ovaries are weak or not responding to the meds, the chances are definitely lower. There was an interesting post from another Instagram group, and I'll leave them nameless out of respect, who said that don't worry if you have diminished ovarian reserve, your chances are still good and your chances of miscarriage are not any lower. And so I messaged them and I said, yeah, that's actually not the case. That's incorrect. And they said, oh no, we're just trying to say that if you have diminished ovarian reserve, your egg quality is not worse. And I said, yeah, actually it is worse. There's studies on that. So I don't think they ever pulled down that post. But the reality is that if you have diminished ovarian reserve, as horrible as that is, and I genuinely feel for everybody that's experiencing this, it increases your risks of pregnancy loss. They've got a study on that. And B, it actually does increase your risks of genetic abnormality, lower embryo quality, lower overall chances. So there's no question that it is a compromise in the overall outcome. So, IVF natural can work really, really well for some of those people. And I actually think the embryo quality is often better than when we stimulate. But, if you've got diminished ovarian reserve, it's a uphill battle. So this is just the best tool we have or the best weapon we have in that battle, but it's still uphill. So it's tough.
I'm 35, almost 36. I've had 3 failed transfers with 3 4 AA 5-day embryos.
Wow.
And 1 early miscarriage at 5 weeks. I've had an ERA says I need 108 hours of progesterone.
No.
We have 3 embryos left. 2, 3, 4 AA 5-day and 1 4 AA 6-day embryos.
Yeah.
I want to ask my RE if we can transfer all 3 to give my next transfer the best chance, given my failure history.
No.
Is there a significant risk of multiples? All embryos are untested.
So you should definitely not do that. You should either watch one of our videos where we talk about all the things you do. You know what? We got to do that. We should do like a flow chart thing and show people what we do. So you know what? We'll do that one of these days. So we have it on almost every show where people ask us what to do, but you need a consult with us where we can go through everything, explain it to you, and figure out what's wrong. And then once you've figured out what's wrong, then go ahead and do your embryo transfer. I'm going to say this again and again and again for the rest of my life, I'm sure. Do not just keep doing embryo transfers unless you know what's wrong. And the ERA test and that 108 hours, that is just patently false and incorrect. I guarantee you are not ready at 108 hours. It's virtually impossible. So if they're doing the right stuff for you, you need a minimum of 120. And if it's a day 6 embryo, you need 144. Do not follow the ERA test. That may in fact be why you're failing. It's useless. It's completely useless. Ignore the ERA test. It doesn't work. They know it doesn't work. They're still doing it even though it doesn't work. So don't bother with it. ERA is hopeless and useless. Don't follow that. Jump on a consult with us. I'll spend a full hour with you. I can probably figure out what's going on. If I can't, we'll do some testing to help you figure out what's going on. Through that, we can come up with a protocol that should and usually does work for you. So don't hesitate. Reach out to us. We'll help you. But don't just take your precious embryos and put them all in. And for God's sakes, 3 high-quality blastocysts, you have a very high chance of ending up with not just twins, but high-order multiples. So do not do that. That's a huge mistake.
How long will my subchronic hemorrhage last? I'm currently 8 weeks, and is there anything I can do to minimize it?
Take it easy. Don't strain. Don't smoke. No heavy lifting, that kind of thing. We generally recommend against sex, only because you don't literally want to rock the boat while you've got some bleeding in there. And then, just kind of wait it out. It will fuse back down again. Certainly, if you're on something that's not good for bleeding, like aspirin, heparin, we typically would stop those. Although, if you have the need to be on a blood thinner because you have a blood clotting disorder, obviously you got to balance the risks versus the benefits of stopping. So that's something you have to discuss with your physician. Don't just jump out there and stop. Yeah.
Dr. B, you said you keep your patients on progesterone after 12 weeks to prevent premature labor. What is the typical dosage?
103 times a day vaginal of prometrium, 1 crinone a day. Endometrium you can't really change, so you can maybe go down to twice a day, but I don't use too much endometrium because women always describe it as vaginal fizz pop. Tarek's face. I don't think anyone likes vaginal fizz pop. A great product. It works really well. It's just people don't like the gush and the mess and all that stuff. So we don't use it a lot.
For a first time being pregnant and being in miscarriage, does this increase the chance of miscarriage for future pregnancies? And how soon before we can try again?
So first time with just one does not increase your risks at all. There is no association between one miscarriage and a risk of recurrence. More than one, it does start to increase your risks. You can start again as soon as you have your next period, so you don't have to wait, and that's actually being studied. There is no need to wait after you've had a miscarriage. You can go right away. Are there questions on Instagram?
Yeah, now that Instagram's on the thing, I can actually just...
Oh, now it's here now.
Yeah, they just...
Finally. That's cool. Cool. All right.
I actually read them all off Instagram right now.
Okay. Oh, all right.
Now we
Amazing.
never have to worry about that again. Literally.
That's awesome.
Decades.
We've been doing it for 3 years, dude.
This problem has lasted quite some time.
All right.
Failed FET with a 4AA fluid embryo.
Okay.
Was on retrace and progesterone. I'm wondering if it's
on
reasonable.
retrace? Estrace.
They put retrace. Maybe.
Must have a spelling mistake. Yeah. Okay. All right. Yeah.
I'm wondering if it's reasonable to try a natural FET or low ovarian stim cycle for our next try. Lining only ever gets to 7 to 8 millimeters.
Well, 7 to 8 is pretty reasonable as long as it's triple layer. I'd probably encourage you to find out why it's only getting to 7 to 8 millimeters. Natural cycle FET is never going to be less successful, and depending on which study you read, it's at least as successful as the stim cycles or hormone replacement cycles, and in some cases they claim it's better. But no one has ever shown that it's worse. So there's nothing wrong with trying natural. My colleague, here's some shameless promotion from my friend Fred Zaneku. So Fred Zaneku and Chloe Remain, who are reproductive immunologists and good friends of mine in Toronto, swear by natural cycles. So when they have patients that fail their IVF embryo transfers, they switch to a natural approach. I don't go completely natural because we use letrozole, but the letrozole helps eliminate the estrogen, and it's the estrogen that's probably doing most of the damage. So if you can skip the estrogen as much as possible, that's probably a good thing. There's nothing wrong with that.
I'm CD15 of my FET cycle. My lining was 6 millimeters on Friday, but was down to 1.5 millimeters this morning. I'm starting estrus today, but I'm feeling quite defeated. Is it all lost, or will my lining eventually thicken?
Say that again. I missed something in there.
I'm CD15.
Cycle day 15.
Of my FET cycle.
Okay.
My lining was 6 millimeters on Friday.
Okay.
But was down to 1.5 millimeters this morning.
Oh, that's the part I missed. Okay.
I'm starting estrus today, but I'm feeling quite defeated. Is it all lost, or will my lining eventually thicken?
No, your lining could easily thicken. I would just want to know why it shrank so much, so make sure you didn't release an egg, because that would definitely screw everything up. But if your progesterone's still low and there's no signs of ovulation, you still have plenty of time to thicken your lining. We have people that sometimes take a month to get their lining to the right thickness, so it's not uncommon.
Had 5 eggs retrieved, 2 made into blasts day 5. PGTA could not be performed, but they will try on day 6. What does that mean? Can they still be frozen if biopsy can't be performed?
Oh, we got to do some art. We really got to get that
yeah,
trying.
Yeah,
you got to work on that.
Yeah.
I need that for next time. Okay, so I'm going to do some drawing for you here. Okay, I'm not an artist. You'll all realize that. So can you see that?
Yeah.
Not here,
Yeah.
on this.
There's a light here.
So there's your embryo. This is the part that becomes the baby. And this is the part called trophectoderm, which becomes your placenta. Okay. So the trophectoderm here needs to come out of the embryo for us to biopsy it. So what we do is we take a laser and we shoot the embryo right there where the trophectoderm is and crack a little hole in there. So then what happens is the trophectoderm kind of bubbles out, and I'll give it that same hatch mark appearance so you can recognize it. So it sticks out of the embryo like that, and you get this little bubble. Then you take the laser this way and you cut off a piece, and you take this sample and you send that. And that's what we're doing when we're doing PGTA testing. So if you laser the embryo and the embryo is not developed enough or expanded enough, it won't push out the trophectoderm, because this part has to grow enough to want to force the trophectoderm out of the little hole that you've created with the laser. So in order to achieve that, the embryo has to expand. If your embryo is not expanded enough, it simply can't be done unless they become much more invasive and they actually go into the embryo, into the trophectoderm, and pull out cells from there, which some places do, but it scares the hell out of me because I think there's too much risk for damage. So by waiting till day 6, you're expecting that your embryo is going to expand enough to push the trophectoderm out so they can biopsy it on day 6. That's perfectly fine. There's nothing wrong with that. We have bucket loads of embryos we biopsy on day 6. Obviously, it's better when they're day 5 because that's a stronger embryo, but there's nothing wrong with the day 6 embryo. Day 7 is where you run into a decrease in success.
I had 5 eggs retrieved, 2 made it to blasts.
That's the same one.
Yeah. My last 2 transfers, I got a positive on home pregnancy test day 5 and day 6. Then day 7, it got lighter. By day 8, negative. Beta day 10 was negative for both. Could this be early chemical?
Yeah, it could be early chemical. I mean, the home preg tests are not that sensitive, so it's hard to know what that is. That could be LH cross reactivity. It could be 100,000 things. So, I mean, if you're going to try something like that, you probably should go and get your serum beta level done just to see if it is nudging above 5, but it's really hard to know. I would never expect a home preg test to be able to tell you 5 or 6 days after an implant if you were positive or not.
Can I take Vitrex while breastfeeding? What's the research to inositol or Vitrex helping to get pregnant with PCOS? Sorry if you answered this, my phone died. So her phone died, my phone vanished. She's in good shape.
Inositol is perfectly fine. I don't believe there's any data on Vitex while breastfeeding, but it's just a combination of herbs. So it's not going to be harmful to you. You can breastfeed well on that. Inositol should be continued for PCOS when it does help. The data on inositol is very clear now. So yeah, I would recommend you take it.
Okay. I had a gastric. This is 2 questions. So
Okay.
like it's spaced up. I had a gastric bypass, and as a result, I have malabsorption issues.
Yep.
Recently, my iron is very low, and I am anemic. I have PCOS and now frequently dizzy, especially during my period.
Okay.
I had my tubes removed after my last baby, so no chance of pregnancy. I asked my birth control to skip my periods until my level gets up. My GP seems to get squeamish with female issues and refers me to a female go who disagrees. Your thoughts here?
Well, if you have anemia secondary to iron malabsorption, then you need to deal with the malabsorption, which is easy. Just get IV iron treatment or injectable if you have access to it. So that's easy to fix. If the problem is that you're also losing iron because your periods are terrible, then we can easily eliminate your period any variety of ways. You could use a progesterone IUD, continuous birth control pill, endometrial ablation, or a hysterectomy. So there's a variety of different options. I would never recommend Depo-Provera, although it'll work. It's horrible for someone with PCOS. But the other ones are all totally viable options for you. There's no reason you can consider one of those. So birth control pill, patch, or ring. You can use the Mirena or Kylena IUD. You could do an endometrial ablation where we burn the lining, especially since you're not planning to have kids because you've already had your tubes removed. Or you just get a hysterectomy and get the uterus out. And that can be done very effectively and easily these days via minimally invasive approaches, whether that's laparoscopic or vaginal. So you got all sorts of choices. Don't feel like you're stuck. And I don't know why your family doc is squeamish about dealing with women's issues, but come see us. We'll take care of you.
No squeamish here.
We don't have any squeamish. I have seen everything. I've operated on brain. Did you know I've operated on brain?
That's new.
I've operated on brain, yeah. I had to clip an aneurysm for a neurosurgeon once. That was wild, yeah.
Can you claim transfer a slow frozen embryo? Can I transfer a flash frozen embryo alongside a slow frozen one, both day 6?
Oh, can we do it? Yes, of course. Can you do, there's no such thing as flash frozen. There's vitrification and there's slow freezing. I'd have to ask our embryologist, but I don't see any reason why we couldn't. It's just a matter of thawing them at different times because it takes longer to thaw a slow frozen embryo. But yeah, I don't see any reason why we can't do them at the same time. It's certainly possible.
With a fibroid, can you do IVF?
Yeah, it depends on how big your fibroid is and where it is and what the impact is. I actually had a chat with a lady online who was supposed to do a consult with us, but she missed it. So she's in the States and her OB told her that she didn't need to worry about the fibroid that was inside the cavity of her uterus because it would have no negative impact on her fertility or getting pregnant or staying pregnant. And then 2 reproductive endocrinologists, thank God, rightly told her that it does, and one of them went ahead and took it out. So yes, absolutely, if you have a fibroid inside your uterus, it's a 50% decrease in success and 100% increase in miscarriage risk. So you must deal with those. But if you have a fibroid dangling off of the outside of your uterus, you don't need to worry about that at all. So it depends on where they are, how many there are, how big they are. But you can definitely still do IVF.
Heard of cases of pregnancy loss after COVID vaccine. Even a friend of a friend at 6 months. Any chances it's related to the vaccine?
To the best of our knowledge, from multiple different studies, including another one that came out on Friday or Thursday with 14,000 women in it, a previous one with 108,000 women in it, and then multiple ones with smaller numbers of women in it, there is not one single study demonstrating an increased risk of any kind of complication in pregnancy related to COVID vaccination. So all I can tell you is what's out there in the data. There is no data supporting an increased risk of miscarriage, pregnancy loss, or any kind of pregnancy complication from being vaccinated with the COVID vaccine while you are pregnant.
How do you differentiate between spotting and bleeding in early pregnancy? I'm 6 weeks pregnant, naturally right before starting IVF with light brown spotting since 14 DPO.
Well, I'm not sure you really can differentiate between spotting and bleeding, other than that bleeding is a little more continuous and spotting is just intermittent. Having said that, it doesn't make a difference to the diagnosis or what's happening. So we've had patients with heavy bleeds that went on to have normal pregnancies, and we've had patients with spotting that went on to miscarry. So the volume of the bleed is not a predictive factor for the outcome.
Hello. That's all you got. When you do a single IVF cycle, does it always have to occur during a follicular phase? Or could you do the regular IVF cycle during the luteal phase? Would this answer change if it's a funded cycle? Question mark.
Oh, cool question. Funded cycle can be done at any time. We do quite a bit of duostim because it does help our patients. And contrary to most places, and I didn't know this until recently doing duostim, most places doing duostim are charging patients more. I find that criminal. than they are for doing 2 individual cycles. So hypothetically, your cost of doing IVF is whatever, $12,000, which would be average. We're lower, but let's just say $12,000. So if you're charging 12 grand for an IVF cycle, and then you go ahead and want to do duostim, some places are charging like $25,000, $26,000, which is more than 2 times 12,000, right? Whereas we're charging like 35% less for that second cycle. So our duostim cost is around 17,000 for both cycles. And we even drop the cost of biopsies and things like that if you're doing PGT, which you should if you're doing duostim. So the major issue with it is that you can split the cycle apart, because we did find after starting this several times that we would do the follicular phase, we'd get ready to do the luteal phase, and the patients just didn't have as many eggs as we wanted. So now what we've started doing is just pulling the cycle apart and doing 2 completely separate cycles. So we'll do follicular phase, let's say October, and then we'll wait for you to have your natural period, and then we'll do your luteal phase stim after a natural ovulation in November. And we're trying that out to see. It doesn't cost anything different to our patients. We just pull the 2 cycles apart for them. So yeah, it can be done from an OHIP standpoint, or not OHIP, but government funding. It makes no difference at all. Yeah.
Hello, doctor. I am 35 PCOS. I'm going into my 5th FET transfer, second one with PGT tested embryos. I've had 2 failures, 1 chemical, and a 5th week miscarriage.
Wow.
HSG done. Docs aren't sure why not pray.
Same thing I said earlier in the show. Story like that, you need extensive investigations. Uterine infection, metabolic evaluation, thrombophilia screening, genetics testing, sperm DNA fragmentation, all sorts of things. If your weight is an issue because you have PCO, you must bring your weight down. Unfortunately, as much as we all want to dance around the issue and be super sensitive about it, the reality is that weight can play a role. Does that discount you from getting fertility treatment? Absolutely not. But does it mean that you got to invest into the process? Yeah, it does. I mean, we need your help to get you pregnant sometimes. So in some cases, that's fighting the battle of the BMI battle. So yeah, I mean, it depends on what's wrong. I always advocate strongly to all of our patients and everybody out there watching, if you've had more than 2 failures, something's probably wrong. And now it could be your embryo quality as well. I don't know, but that's a situation where you reach out to someone who is competent and who is well educated and who's willing to listen, because most places just want to jam you through another cycle. I personally feel like if it doesn't work on each individual try, that we are somehow failing you. I hate that. Like, it makes me feel awful. So I don't want to jam people through another cycle. Like, we hate repeat business. I want you to do 1 cycle, 1 transfer, get pregnant, go tell your friends. So we do everything possible to make that work. So yeah, talk to us or talk to someone like us who can help you. Don't do another embryo transfer.
Hi, Dr. V. You mentioned that your patients continue progesterone suppositories after 12 weeks to pregnant premature labor.
We did that one.
That's what I was thinking of. But then is a dose of 200 milligrams endometrium per day sufficient? Did she ask that?
No, she didn't. But 200 milligrams of endometrium would be fine. 100 milligrams 3 times a day of prometrium, or 1 crinone gel pack per day.
Oh, skin.
You were scared. All right.
I have endometriosis.
Okay.
And about to do IVF.
Okay.
I'm now taking estradiol. Is it okay to take aspirin?
You should minimize your taking of estradiol. You should take none, because it's stimulating your endometriosis. Aspirin is, I would argue, mandatory for you. It reduces inflammation. So yeah, take aspirin for sure.
I just had a lap and hysteroscopy.
Okay.
I have adenomyosis and 2 spots of stage 1 endo. What would be the best step to transfer?
I have adenomyosis and stage 1 endo, 3 months of Lupron and letrozole for suppression, maybe up to 6, NAC, curcumin or turmeric powder, coenzyme Q10, yoga, lots of vitamins, super healthy diet, organic everything, and then go for your embryo transfer, not using estrogen. Use letrozole to stimulate your lining and avoid using estrogen as much as humanly possible. Get all your vitamin levels up. Make sure that you're getting your progesterone in oil and vaginal. Get your levels measured. Go from there.
Get ready.
I'm ready.
I plan to transfer this month.
Okay.
But so scared because I only have one embryo.
Oh, okay. All right.
That's it.
That's it? That was the same person or somebody else?
No, that's something else.
If you only have one embryo, guys, it's really obviously super precious. Not that each individual embryo isn't precious, they are. But I mean, we got people with 11. If they've got 11 embryos, and you don't want to do a whole bunch of fancy testing, you don't have to because you've got 1 or 2 embryos that you can try. If you only have one, my advice is do everything humanly possible to make that work. Otherwise, don't transfer the embryo until you're ready. So vitamins, supplements, naturopath, acupuncture, all the holistic things you can think of, prayer, meditation, diet, Mediterranean diet, weight, exercise, make sure your stress level is low, get a really good transfer protocol, make sure your vitamin D is adequate, make sure your iron is adequate. Don't take chances. You've only got one embryo.
For women who are able to conceive but not carry the pregnancy to term, what kinds of testing would you recommend? I've looked into ERA.
No.
I'm not interested in this test. So one of your bids as well. Thank you.
Yeah, so I mean, we've talked about that kind of the whole show. This has been like the tough embryo transfer show.
Oh yeah.
Yeah. That maybe that should be our video. If you bring me a drawing thing, I could like draw out what to do. I need that next time.
This is a big show today.
I know it is.
A big show today.
So you know what? That's a tough one. So, make sure you follow through again with someone like us who can walk you through each step of the testing that's necessary. You need your immune system checked. You need your blood checked. You need your infections checked. You need the shape of your uterus checked. You need your overall health checked. We need the vitamin levels checked. We need your partner checked because he's contributed half or whatever sperm source there is. So there are all sorts of potential areas that we need to explore in order to figure it out for you.
If SIS is done, do I need to do a tubal test as well, or is it done during the SIS?
It's done during the SIS if it's done properly.
Dr. V, you have mentioned before that sex prior to an FET is beneficial due to the male's ejaculate. How close to an FET can you have sex?
All the time. You should be having it regularly leading up. I have to say, from the physician standpoint, and please forgive me for this, it is kind of gross to find it there when you go to do the embryo transfer. And that's probably not optimally timed. But the night before, 2 days before, anything like that, that's perfectly fine. Maybe just not the same day as the embryo
Why
transfer.
does the estrogen causes damage during a medicated FET?
Estrogen causes inflammation and supraphysiologic levels of estrogen, which is not needed. So you don't want a lot of estrogen. Plus, for those that have endo, it's stimulating their endo. So that is never a good idea.
How closely would you monitor a eclampsia and HELLP syndrome patient?
HEELP? Help? HELLP? Help and preeclampsia? Oh. Well, I mean, if they've got HELP syndrome, they're in the hospital. If they've got preeclampsia, and it's actual preeclampsia with proteinuria, you're in the hospital. So we monitor you like a hawk. I mean, if you've got HELP, you need to be induced. It doesn't matter how far along you are, you need to be induced. If you've got preeclampsia, there are some people that would feel comfortable monitoring you at home with regular urine protein checks or blood work and frequent testing for your blood pressure and your labs and so on, I'm known for being conservative. So I would not let you be at home. So you'd be in hospital. We'd be monitoring you all the time. Daily blood work, daily 24-hour urines, all of that stuff. This is a topic that's near and dear to many people here. So yeah. It's 9. Are there tons more questions?
Oh, it's 9. Oh, yeah.
Is it crazy tonight? Crazy. What do you want to do? 9:10?
Whatever you want, boss.
You got to go?
No, I got it.
All right, 10 minutes. Let's give them what
Give
they
them
what they paid.
for.
Yeah, give them what they paid for.
Sure. Hey, Dr. Victory.
Hello.
I had an FET today and wanted your input on what my chances of success might be.
Oh my
We
God.
transferred 2 donor embryos untested, grade 5 BA and 4 AB. Donor has a history of 0 failed cycles. First transfer for her, they transferred 2 and 2 stuck. For second transfer, she transferred 1 and it split. So 2 sets of twins. She did not have fertility issues either. She needed a male donor via sperm bank. As she's a single mom by choice, so she just did the IVF. I have tons of testing, HGG, hysteroscopy, biopsy to check for inflammation, tested for clotting issues, and NK and thyroid antibodies, plus tons more.
And
What is the purpose of doing 20 units of Lupron after? Oh, I guess that's the end of that question. Then she asked another question afterwards. Yeah, that's.
I mean, as long as there's nothing wrong with you, your chances should be exceptionally high. I don't know how old the embryo donor was, but I mean, that sounds pretty much like a slam dunk. So you should have a very good chance. I don't know what the rest of that question is. Purpose of giving 20 units of Lupron when?
After a FET. After and FET is what it said.
20 units of Lupron after an FET?
Yeah.
I cannot think of any biological reason why you would do that.
You can answer that question.
I'm going to need to look that one up. Never heard of that being done before. We give Lupron before, but I don't know why you give 20 units of Lupron. That makes no sense. Unless they're trying to trigger something. I don't know. I'd have to think about or read about why they're trying to do that. Maybe they're trying to get you to release an egg. I don't know. I'd have to figure that one out. Never heard of that before. I got stumped. It takes a lot to stump me, actually. I'm kind of proud of that.
Facial reaction often.
No. I'm going to need to look that one up.
What is the ideal lining measurements for an FET? Also, I had a day 6 embryo, but it couldn't be biopsied for genetic testing as it didn't batch out. Does that
hatch out? Yeah.
Hatch out. Does this mean it's lesser quality than those that do hatch?
Well, yes, it does, because that means it's a lower number, like a 3 instead of a 4 or a 5 or a 6, or 2 or a 1, whatever it is. So it is a lower quality with a little bit of lower chance. In terms of what was the first part?
Didn't hatch out.
Before that,
day 6 embryo, but it couldn't be biopsied for genetic testing as it didn't hatch out. Does this mean it's lesser quality than those?
It does mean it's a lesser quality. Was that the only part of that question? Oh, okay.
Ideal lining measurement.
Ideal lining measure. That's what it was. 8 to 10 millimeters. Trilaminar appearance. So 3 layers.
Hi, Dr. V.
Hello.
I've mentioned before. Oh, no. Does estrogen cause damage? No. How closely would you monitor? Oh, yeah. Here we go. Hey, Dr. V.
Tonight you are on fire tonight.
Hey, Dr. V. Just wondering.
Yeah.
What type of birth control do you recommend to help with endo? Mini pill, combo pill, or does it matter?
So if you're in Canada, you should probably use Vizan. It's not birth control though, but it's the strongest pill we have, or one of the strongest pills we have to control endo. If you're in Canada or the US and you want to control endo, Orilissa would also be extremely strong. Again, not birth control, but highly unlikely you'll get pregnant on Orilissa. If you want actual oral contraceptive pill, Anything with a reasonably strong progesterone and a low dose of estrogen. So low is probably your best bet. Your next best bet would be a less. So any of those would work.
After a successful FET, at what week do you recommend to stop progesterone shots?
12. We continue ours till 12. I know it's torture, but I'm too paranoid to stop it any earlier. And it's not really until then that the placenta fully takes over progesterone production. So I don't see the biological value of stopping it earlier.
I've had one FET and it failed. Untested embryos, but have 9 left. Would you recommend changing anything for the next FET?
Not if you've got 9 left. I'd probably just try one more. It depends on your age, of course, but if you're like 35, 50% of your embryos are going to be abnormal. So it's entirely possible that the one that they chose for you was abnormal. So no, I always, if I have enough embryos, I'm pretty much a supporter of trying at least twice before you do anything else. If you don't have enough embryos, yes, I would do a bunch of testing, but with 9 left, I would just try one more time. If it still doesn't work after that, yeah, you need some testing for sure before you do it again.
During PGT, how can you tell an embryo is mosaic if you only biopsy the placenta?
You can't. That's the whole problem with mosaics. So we don't know if the embryo, the inner cell mass, which is going to become the baby, is normal or not. And you can't biopsy that part because that damages the baby. So it's a great question. I'm really amazed that you asked that. But the reality is they're now pushing more and more to say that low-level mosaic embryos are likely normal embryos and should not even be called low-level mosaics. They should just be considered normal. High-level mosaic embryos are probably not genetically normal. So those ones definitely is a different issue altogether.
How does NAC and Oxetol and metformin each benefit PCOS patients? Would they help me get a normal period back? Haven't had one without Provera or other meds since stopping BC in 2019.
That's birth control. Yeah, so we don't know about the exact mechanisms of how each of those work. Inositol does seem to be an insulin sensitizer, so that may be its mechanism there. CQ10 and NAC, I don't think anyone's really fully worked out how it helps, but there are clinical studies that support it. Will it make you regular? It might. The reality is that with PCOS, it's always the 3-pronged approach, and we can probably end on this one. So PCOS is never going to work unless you do 3 separate things. So number 1, you got to deal with medication. So the medications are metformin and letrozole, or Clomid, but letrozole is better for PCOS. Number 2 is the supplements. So NAC, inositol, and CQ10. There's a bunch of other ones, but those are the big ones. We do have a video, probably 1.5 years, 2 years old now, looking at what natural PCOS treatments actually work. So check out that video. It's way back on YouTube. It should have had thousands of views. We should promote that one again. Maybe bring that back to life. Yeah. And then number 3, lifestyle changes. So lifestyle changes are critical for women with PCO if you're in the not thin category. So remember, there's thin PCO where the women are really thin, and there's not thin PCO where the women are unfortunately struggling with their weight often. So in that category, lifestyle changes are imperative or it doesn't work. So you must lose weight and bring your body mass index down. And at the same time, in order to do that, you must eat a healthy diet, and that's 6 meals a day with low calorie intake spread out across the course of the day. And you must build muscle. So you got to do HIIT training or weight bodybuilding or whatever in order to bring your body mass index down as much as possible. So you have to have all 3 of those: meds, supplements, lifestyle changes. Just trying one, it doesn't work. It's a waste of time. Are we good? Is there like Tarek's terminal question, or should we end it? There's so many. Tarek fell asleep a moment ago, folks, so we got to end it now. So thank you for joining us. I am so excited to know that so many people were watching. hang on to your questions, post them to me personally. I'll make little things out of them. If any of you didn't get your questions answered, send me a DM. I'll turn them into some of those stories and I'll answer them that way for you so you still get your questions answered. We're excited to see you again next week. We'll find another exciting topic. Let us know in the comments for sure what you thought of this segment, because we want to know if we should start doing some non-fertility related stuff as well.
8% of the votes.
80?
80 said you can do non.
Oh, really? Oh, wow. Okay. Well, 80% said we could do non-fertility, so we'll start doing some of that. So that makes my life easier too. Maybe we'll pick up something gynecologic next time and just kind of rotate between gynae, OB, and fertility. It's going to be a whole new world. All right. We'll have to change the name of the show. It won't be Fertility Factor Fiction. It'll be Gynae Factor Fiction or OB Factor Fiction. All right, guys. A reproductive factor fiction. We'll figure it out. You guys have a great evening. Thanks for joining us. Take care.